Good evening, everyone. Welcome, and thank you for joining us for this year's Royal College of Pathologists BDIAP Foundation and Undergraduate Taster event. I'm Angharad Davis. I'm Vice President for Learning at the College and a Consultant Medical Microbiologist in Swansea. And before being in the VP role, I was the college's joint lead for undergraduate and foundation education. So this event is very close to my heart, and I'm delighted to have the privilege of welcoming you all to our third taster event. And this is the second one actually that we've held virtually. It's fantastic that so many of you out there are interested in finding out more about the pathology disciplines. We had interest from over 200 people registering through the website, which is fantastic. You'll notice that your microphones are all muted and the videos are turned off in the webinar format so that there are fewer distractions. You'll be able to ask some questions through the Q&A function later on during the panel discussion. And if you're using Twitter, we're using the hashtag #WeLovePathology. So this slide shows you the programme for the next hour and a half or so. First of all, we'll hear from Dr. Mike Osborne, College President, and after that we'll be introducing the RCPath Foundation Fellowships and hearing from two of our current fellows, Stephanie Widya and Movin Abe-Wikrema, about their experiences. And then I'll be handing over to Dr. Matt Clark, who is chair of the RCPath Trainees Advisory Committee, and he's also a specialty trainee in diagnostic neuropathology at UCLH. And Matt is going to talk you through an interactive mystery case and chair a Q&A panel with our representatives from the different specialties. I hope many of you have had the chance to watch the specialty videos which the panel members prepared. And the Q&A will be your opportunity to ask questions to them all about their specialties, training, selection and interview processes. We'll then have a short presentation from Abby Ghosh of the BDIAP, our sponsors tonight, and some advice on how to organise a local taster day and some of the competitions and awards that we run for students and foundation doctors. These are the guest panelists who are participating in the Q&A panel. I'm really very grateful to all of them for finding time not only to join us tonight, but also to produce the videos which you'll have seen in advance of this event. So from chemical pathology, we have Dr. Ruth Ayling and Dr. Josh Newmark. From hematology, Dr. Kath Booth and Dr. Thomas Erblich. From cellular pathology, Dr. Mike Osborne and Dr. Katie Allen. From immunology, Dr. Shoaib El Khalifa. From microbiology, virology and infection, Dr. Ali Robb and Dr. Ian Blythe. And we also have Joanne Brinklow, Director of Learning for the college, for questions about curriculum advice. So when you all registered for this event, you were asked to provide 3 words which you associate with pathology. And we used these to create a word cloud. The bigger the word, of course, the more often it was cited. And what really stands out alongside the diagnosis and detective aspects is, I think, a very strong reflection of the intellectual side of pathology with words like research, science, academic and knowledgeable. It's good to see that these continue to be highly valued by potential future pathologists such as yourselves. And it's also good to see words there like diverse and varied, because we are a very diverse bunch of people in all sorts of ways and with a huge variety of work that we do in the different disciplines. So I now have the pleasure of handing over to the college president, Dr. Mike Osborne. Mike's a consultant histopathologist at Imperial Healthcare NHS Trust, where he's clinical lead, and he divides his time between postmortems, diagnostic GI histopathology, bowel cancer screening and teaching. And I'm very grateful to you, Mike, for finding time to join us this evening. Thank you.
Thanks very much. And thank you very much. Hello and welcome to this evening's Pathology Taster event. My name is Dr. Mike Osborne and I'm President of the Royal College of Pathologists. I'm also Secretary of the British Division of the International Academy of Pathology, the BDIAP, and this event is brought to you by both these organisations today. So welcome on 2 fronts. So why is pathology such a great career? Well, the Royal College of Pathologists represents all branches of pathology, and there are 17 of these currently. So within the umbrella of pathology, pathology offers a whole range of specialties, meaning there's a very wide choice of careers on offer in pathology. And as a result of this, there's something for everyone. So some involve a lot of patient contact, for example, some aspects of hematology, microbiology, immunology. Others have very little patient contact at all, for example, histopathology. Some are very laboratory-based, for example, chemical pathology. Others do not involve a doctor in the laboratory hardly at all. For example, forensic pathology. A forensic pathologist would almost never go into the laboratory. But all our specialties are patient-focused and play a vital role in patient care. Without pathology, medicine is essentially just guesswork. 70% of all healthcare interactions involve pathology of one sort or another. So pathologists are absolutely central to all of healthcare. While pathology offers a whole range of specialties, even within each of our 17 specialties themselves, there are a whole range of opportunities. And what this means is that you can tailor the job to your interests and what you want to do. So for example, some pathologists concentrate on diagnostic work. They might run, for example, a virology lab or diagnose disease at a tissue level, for example, in histopathology or cytopathology. Others are very involved in research. This might be in the clinical setting, in a hospital. It may be in a research institution, a laboratory in a university, or it may even be involved in industry and developing things with industry. They work to develop, for example, new tests, new treatments, new drugs. And this work for pathologists in research has been demonstrated with all our members' contributions, particularly in the area of the COVID pandemic, where they've helped develop vaccines and helped develop many of the tests that are used for testing if people are positive for COVID, their response to vaccination and to infection and so forth. A particular area that touches on this is the area of genomics. So pathology is very, very involved in the whole aspect of personalized care, genomic investigation, particularly in cancer, in rare disease, but touching on all aspects of pathology. And this is an area that is going to develop very much over the years to come and is something that pathology is absolutely central to. So that's a key area that we're involved in and is a very much a developing area. And if areas of genomics and genetics excite you, pathology offers a huge range of opportunities within that. Pathologists are always very much in demand in research. And as a result, pathology is an excellent way into academia if that's what interests you. But even on a project to project level, any pathologist can get involved in high level research if they want to. Even if wherever they work, it's easy to get involved in very good research projects because pathologists are so much in demand. Other pathologists are very involved in teaching. This may be undergraduates, it may be postgraduates or allied professionals in a whole variety of areas. Because pathology covers so many areas of healthcare, there are lots of opportunities for teaching and training. In my own work, I actually run a humanities BSc, which is quite unexpected for somebody who does pathology, but that's a complete spin-off of things I've done through pathology. So that's just an example of the opportunities that are there. Many pathologists combine aspects of several of these roles, diagnostics, research, teaching, to create essentially a portfolio career that suits them and means that they have a variety of activities during their job. Because pathology interacts with so much healthcare, it provides the opportunity to work closely with lots of other specialties. For example, I've worked very, very closely with the London Air Ambulance team, which is not really something you'd expect for a diagnostic histopathologist, but I've been involved in lots of teaching and training with them and learning from issues around the care of their patients and feeding that back for them. And that's given me a lot of insight into their work and a great opportunity and has been a lot of fun. So because we interact with so many groups, there are a huge range of opportunities in pathology. Pathology is very good at providing these unusual opportunities if you want to take them. Some people do, but others want to concentrate on the more core activities, the diagnostic or the research activities, and that's fine, and there's plenty of opportunity to do that if you want to. But there are other reasons, apart from the core job reasons, that pathology is a great career. For example, there are lots of jobs in pathology in most of our specialties. So this means you can work pretty much wherever you want around the UK or indeed around the world. And pathologists are always in demand. So if you want to move to different regions or you want to move to different parts of the world, there are likely to be job opportunities for you in those areas. Pathology is also very family friendly. There are many pathology specialties that have limited or no on-call, for example, many areas of histopathology. So that's very good. Also, we work very hard in pathology to support flexible working, things like working from home. This can be very good for family life, very good for things like childcare, which may not seem important to you now, but may be important in years to come. And we very much believe in embracing new technologies to help us do this and to work more flexibly. So, for example, digital reporting of histopathology is an example of this. Pathologists have a reputation for generally being very friendly and very welcoming to everybody. Pathology departments are happy places. Pathologists tend to be happy too, most of the time. And pathologists tend to have interests outside their job. So all of this works together to give a very good work-life balance in pathology, which is really, really good and leads to people having a fantastic job and experience of working life. Pathology is much less taught now in medical schools, and as a result, people do not necessarily think of pathology as a career option. But pathology offers great opportunities, as I've highlighted. And those that choose pathology rarely feel that they've made a mistake. I work in a very big training centre in a very big city. We all the time have 20 or so pathology trainees attached to our unit, and these include 4 or 5 ST1 trainees who are just starting out on their speciality careers. But we rarely have a trainee leave the specialty. And this is fairly typical around the country in all the specialties in pathology. And people who start out in our specialties tend to be pleased with their choice. So whilst it's not something people may immediately think of, it is certainly something people are very pleased that they have chosen when they choose it. So if you're looking for an exciting job that offers huge opportunities in a role that you can tailor to suit you, that's family and lifestyle friendly, welcoming to you, then pathology is it. I recommend a career in pathology to you all. Whoever you are, wherever you come from, there's a role for you in pathology and we'll make you very, very welcome. We would love to have you as a colleague. I look forward to welcoming you into pathology and into the college and the BDIAP in years to come. Thank you.
Thanks very much, Mike, for that excellent introduction to pathology and why it can be such a stimulating career and such a good choice. Mike will be in the Q&A session too in the panel, so if you have any questions for him, that'll be your opportunity to ask him then. So next up, we have got 2 of our Foundation Fellows. The Foundation Fellowships are a new scheme which the college introduced last year. They are a really good opportunity for foundation doctors who are rotating through any foundation post which contains a pathology discipline within it. So for example, that might be infection, it might be hematology, histopathology, or any of the other disciplines that the college represents. If you go to the website, you'll be able to find out more about the various benefits of being a Foundation Fellow. Last year, we appointed our first cohort of 25 fellows, and applications are currently open for the 2021 round. And the closing date is the 31st of August. So I hope to see some of your applications by the end of August. Another recent development in Foundation is the introduction of the new Longitudinal Integrated Foundation Training, or LIFT, in pathology, which some of you may be familiar with LIFT. It's a foundation arrangement in which you work 4 days a week in your acute medical specialty or acute surgery or other main discipline, and then 1 day a week in something else, and in this case, pathology. And from August, there will be pathology-related lifts running in Southampton, in Swansea, and in Cardiff. So watch out for those as well, because they're a really excellent opportunity to try out pathology during your foundation years. So this year, since we have our first cohort of Foundation Fellows, we're delighted that we can include some of them in our event this year. You may have already seen posters from two of them, Dr. Ryan Mohammed and Dr. Nayanatara Pubalan, which were displayed alongside the pre-event videos. And I'm very pleased this evening that we're joined by another two of our inaugural fellows to tell us about some of what they've been up to during their Foundation Fellowship periods. So the first up, welcome to Dr. Stephanie Widya, who has been a Foundation Doctor in Haematology at Kettering General Hospital. Welcome, Stephanie.
So my name is Stephanie. I'm a current F1 working at Kettering General Hospital, and I'd like to share with you my experience in working in haematology during the COVID pandemic. It was a service evaluation assessing the outcome of patients with hematological conditions in our hospital. So we know that risk factors for severe COVID-19 infection includes advanced age, current malignancy, and immunosuppression. And we know from systematic reviews, such as the one by the American Society of Hematology, that patients with hematological malignancies have a higher mortality rate of 32 to 40% and a higher admission to ICU rate. So the aim of our service evaluation was to investigate the mortality and morbidity of patients with hematological conditions in our hospital that had acquired COVID-19 infection. And we did that by acquiring patients' data from March 2020 to April 2021 of patients with hematological conditions with a polymerase chain reaction nasopharyngeal swab that is positive for COVID-19. So we found out that the main reason for admission was actually not majority of COVID pneumonitis. They were admitted for elective chemotherapy, neutropenic sepsis, and abnormal bloods. And the majority of our 21 patients were aged more than 50, so advanced age and immunosuppressed. We also broke down the hematological disease from hematological malignancies and hematological non-malignancies such as ITP. So the result from this service evaluation was that out of the 21 patients, 3 did not require hospital admission, 9 was able to be discharged, and unfortunately 9 out of the 18 died. So that accounts for a 50% mortality of the patients that were admitted into the hospital. And we also found out from a breakdown of a classification based on the national linkage study that only 7 out of 21 patients had a community-acquired COVID transmission, whilst the remaining has a hospital-associated COVID transmission. So interesting discussion points from this that I learned was that our patients had significant comorbidities and they were older and immunosuppressed, therefore they had a severe outcome. And also due to this, only 4 out of 21 actually made it to ITU as they were unsuitable for ITU care. We also noticed that neutropenic patients, which was about 3 out of 21, actually had mild to no symptoms. And this might be due to the fact that they had reduced cytokine release during this period. And when they started to develop their neutrophils, they became more symptomatic. We also noticed from their viral loads that they had prolonged courses of infections and they had increased transmissibility. And this could account for the fact that most of them were hospital-acquired COVID infection. And this led to discussion of better infection control for them. So our service evaluation supports the previously published data that patients with hematological conditions, especially malignancies, have high mortality and morbidity rates. They had prolonged hospital stay. Majority of our patients stayed about 24 days on average in the hospital, which could delay also their further hematological treatments. And this accounts for also more morbidity in their outcomes. So we acknowledge that this is a quite small service evaluation, and we know that more research needs to be done in specific risk factors in a larger group of patients and going in more in depth into the different types of treatments that can be given to them and also ways to protect them further from COVID-19, such as more studies on vaccinations. So that was my experience in hematology as an F1. Thank you so much.
Well, thank you very much, Stephanie, it's great to hear about your experiences in your haematology placement, and thanks very much for sharing that with us. It's very interesting and such a timely project as well. So brilliant, thank you. And now I'm pleased to introduce Dr. Movin Abewikrema, who is a Foundation Doctor in Microbiology at Queen Elizabeth Hospital, Birmingham. So welcome, Movin.
Thank you so much. I'll just share my screen. So my name's Movin. I'm an F2 based at the Queen Elizabeth Hospital in Birmingham. So I did an F2 rotation in microbiology, and I was particularly interested in infectious diseases and microbiology throughout med school, but I didn't really know what to expect from a microbiology rotation as an F2. And my experience kind of communicating with microbiology previous to that was as a panicked F1 over surgery, and asking about patients when I was particularly concerned and needed advice from the microbiologist. But in terms of doing it as an F2, I found it a really inspiring experience and got the chance to speak to a lot of role models from the registrars and consultants. So first of all, why microbiology and infectious diseases? The last 18 months have shown us that this specialty is particularly evolving and is an opportunity for research, given the last everything that's been going on with the global pandemic. And I find this specialty particularly interesting because of the multi-system nature of it. During my FT rotation, I got to deal with doctors in hematology, neurology, liver, renal, intensive care. And it's one specialty where you get the chance to speak to doctors across the whole hospital. It's a specialty that naturally lends itself towards public health and thinking about infection control. And I found that side to doing the F2 rotation particularly interesting, especially in the context of COVID, where we had multiple issues in terms of planning, minimizing spread of infection around the hospital. And I was involved in meetings where we discussed infection control issues. And also in terms of thinking ahead for the future and thinking about antimicrobial resistance, which is going to be one of the major issues that we face as a career. I think this is a particularly interesting field to be within. So in terms of my routine as an F2, in the mornings, I would be involved in carrying out consults with patients for whom the teams on the wards had put in queries about. The Queen Elizabeth Hospital is a combined microbiology and infectious diseases service. And so we would go around the hospital and carry out histories and examinations of patients. And then afterwards, we'd do a daily board round in intensive care and discuss the patients there. And then in the afternoon, I would get the chance to actually answer queries from the wards. So those would be queries regards to the choice of antimicrobials that patients were on for various infections, durations of antimicrobials, and also answering queries about pyrexes of unknown origin. So I find infectious diseases and microbiology particularly interesting because it's a specialty where when there's clinical uncertainty, you'll often be called in to liaise with, for example, hematologists and rheumatologists regarding pyrexes of unknown origin. And also, as discussed before, it's a specialty where you think about not just kind of individual patients, but also infection control and minimizing spread of infection around the hospital. And doing the rotations as an F2 was a great opportunity for learning experiences. So often in the afternoons, I'd have very frequent teaching sessions with the registrars and consultants, and my knowledge of antimicrobials significantly improved following that rotation. I also got the chance to spend some time within the lab as well. So I got to see the plating of various culture specimens and also the analysis of culture sensitivities as well. So that was really helpful when answering queries from the war teams, because having had that experience, it was more easy to interpret the culture results in that context. So just to touch on a few cases from my rotation. So I got to see a case of Legionella pneumonia. And another case that I found particularly interesting was in a patient who had a Staphylococcus aureus endocarditis and had a disseminated infection resulting in discitis as well as a cerebral abscess. And so that was quite an important learning point for my experiences in identifying both sources and seeds of infection. And also, although we haven't had that many returning travellers this year, I did see a case of a returning traveller who had a dengue viral infection. So that was particularly interesting, and seeing how the infectious diseases doctors triaged that and then ordered various diagnostic tests for various different differentials. And doing an F2 rotation is an opportunity to get involved in various projects as well. So in the context of COVID, we saw that there were a significant number of false positive PCR swabs. At the time that I did my rotation, which was at a low prevalence period relatively low prevalence period over the summer 2020, we needed to recalculate the positive predictive value of the swabs that were done on one of the machines in the lab. And this was particularly pertinent because of the incubation period prior to symptom onset in COVID, as well as the period following the infectious period, where viral titers are still in the intermediate zone. And so calculating a threshold that would be an optimum to dictate a positive swab result is particularly important in minimizing false positives. So what I did was compare the titers, viral titers from one machine, and compare them to a different machine based on the relative light units that were emitted from the amount of RNA within the swab. And then by comparing the two machine outputs, I was then able to calculate an optimum threshold to minimize false positives from a particular COVID machine. So overall, I really enjoyed my microbiology rotation, and it was a great opportunity to get involved in answering queries from the wards, having been on the other side as an F1. And I would really recommend that if you're interested in a career in infection.
That's great. Thank you very much to Moven and Stephanie for those excellent presentations. Actually, I really enjoyed listening to them, and I hope you did too. It's really great to see two junior doctors getting involved at pathology in an early stage and producing some great results. So thank you very much for coming and talking to us tonight. Good evening, everybody. My name's Dr. Matthew Clark, and I am a neuropathology trainee, and I'm also the current chair of the Trainees Advisory Committee for the Royal College of Pathologists, and also the BDIAP Deputy Meeting Secretary. And a big welcome to you all tonight, and fantastic to see so many of us joining us this evening virtually. So I'm just going to share my screen now. So this part of the session tonight is going to feature a discussion about a mystery case. So it's going to be an opportunity for us we're taking part effectively in a virtual multidisciplinary team meeting full of pathologists. So we're going to get an opportunity now to work through a case, and it'll be interactive, so there'll be some polling for you to take part in as well, to get your views across about what you think you'd do next as well, and also hear about things from some of our experts about what they would do presented with these different results as well. Just to remind you as well, after this session, we're going to have our live Q&A panel discussion with the panelists as well, and you'll see at the bottom of the screen there's a Q&A tab function. I can see some people are using it already, which is great. If you have any questions about any of the specialties or about training, etc., please feel free to put those questions in the Q&A function, and we'll address those after we've done our mystery case discussion. So let's see what we've got. Let's just go through our history. So this is Jane. So she's 37 years old and she's generally fit and well with no significant past medical history. But the trouble with Jane is that she's had an ongoing fever for the last few weeks. She's been suffering with night sweats and also feeling very tired and has had some weight loss as well. Family have also commented that in recent weeks she started to look quite significantly pale. So something's not quite right with Jane. And as expected, she's gone to see the GP to try and work out what's up with her. So the GP takes her history and doesn't get any more sort of additional information than what we've already established currently. But he notes that she's got quite pale conjunctiva and mucous membranes, but her temperature is up at 38.3. So she's pyrexial at the moment. So there is something going on here. He does his general examination as well. And on an abdominal examination, he thinks there's possibly an enlarged liver that he's noted when he's examining her abdomen. But he decides to do initially some basic investigations, including a full blood count in U's and E's, etc., just to see what the situation is and try and see if that can help make a diagnosis for Jane. So here we've got our full blood counts and some other possible relevant tests. And so you can see here I've highlighted in red some of the results that aren't quite right. So a hemoglobin is low down at 80. The MCV is also abnormal. White cell counts, which are the immune cells of the body, are again on the borderline of being quite low. And also her platelets are also quite low as well. We've got ESR and erythrocyte sedimentation rate, which is increased, but also LDH enzyme is also increased as well. So I'm going to come to our hematology colleagues here. I think we've got Catherine and Thomas. What do you think about these results, Catherine and Thomas? Any thoughts initially about what potentially might be going through your mind, or any other investigations you might consider doing?
Thanks, Matt. So it looks like we've got a slightly macrocytic anemia with a normal low white cell count, but we haven't got a differential there, so don't know what the breakdown of the different white cell types are. A slightly low platelet count. So sort of things that go through my mind. I certainly want to know about hematinic. So with a macrocytic anemia, could this be a B12 or folate deficiency? Another thing with this, the raised LDH, could this be hemolysis? So I'd want to know what her reticulocyte count was, and a full hemolysis screen. And being a hematologist, I think we always want to look at the blood under the microscope. So I think that would give us some more clues.
That's brilliant. Thanks very much, Catherine. You said about the white cell count. What do you think about that? Is it important to have a look at the differentials of the white count and what it's made up, or what that 4.2 is reflective of?
100%, yep. Because if it could be completely normal, or she could have a severe neutropenia and a lymphocytosis, which then would take us down a kind of completely different avenue.
Okay, that's brilliant. Thank you very much. Any other investigations you might want to do? You mentioned about the blood film. Anything else? The hematinics you said as well might be a useful investigation. Anything else you'd want to consider, perhaps? And
then we mentioned the possibility of hemolysis. So things like the reticulocyte count and bilirubin. You might want to do a DAT. So that's looking for, could this be immune hemolysis?
That's brilliant. That's lovely. Thanks very much for that, Catherine. That's really helpful. So hemolysis, potential differential diagnosis from the hematologist here. So let's now have a look at our urea and electrolytes and our LFTs for this patient. So sodium and potassium are okay. The potassium's on quite a little bit on the high side of the normal range here. Urea is elevated though at 7.6. Creatinine is 200. EGFR, the filtration rate is lower than it should be at 56, and we've got quite a low albumin as well. And the three results at the bottom, for those who are not familiar, they're a reflection of what we call the liver function tests. And you can see that 2 of those are actually elevated as well. And when we think back to our initial examination of this patient, the doctor noted that there might be an enlarged liver here. So we've got a sort of biochemical result that may be correlating with what we're finding clinically on examination. Now, I'm going to come to our chemical pathology colleagues here. So I think we've got Ruth and Josh on the line. So any thoughts about what these results might mean, Ruth and Josh?
Thanks, Matt. There's nothing diagnostic looking at these, but it would suggest there's perhaps evidence of an acute phase response and certainly 2 organ involvement. There's a low albumin and impaired renal function and abnormal liver enzymes with a predominantly hepatitic rather than cholestatic picture. Hard to know whether the renal function is acute or chronic. The fact that the potassium isn't dramatically elevated would suggest that it's not sort of hyperacute, but it would be good to see some previous measurements if there were some available. In terms of what to do next, it's very difficult. I'd certainly be thinking in a sort of fairly young person, is this an inflammatory condition? Is there evidence of malignancy, or potentially looking at metabolic conditions? And certainly it could be an inherited metabolic condition, something I wouldn't want to miss in somebody who had renal, liver involvement and had evidence of hemolysis would be Wilson's. So I'd be trying to keep, at this stage, casting my net fairly wide.
Thanks very much, Ruth. And you mentioned a really good point about these investigations, that they're in isolation. We need more information, don't we? So any previous ones that have been had to see if there's a trend going on, it could be quite valuable to see what's actually been happening, whether this is an acute phase problem or or something that's been going on more chronically as well, definitely. And interesting, so with we heard about the hemolysis that the hematologists are thinking about from the blood results. Do you often look at the full blood counts and other investigations that have been done alongside these, the ones specifically to you, to sort of give yourself more of an idea?
Well, I often go and ask Kath, actually, but yes, I think it is important to not only look at your own specialty. Yes,
absolutely. So pathologists don't work in isolation. We work together. We're not just confined by one specialty. There's so many of us, and often we're on the same building as well, which is really helpful to perhaps either pick up the phone or pop up to the next floor and see what other people think. So thanks very much, Ruth. Really useful insights. Now, another clinical update, and this is another really important point to make about this, is pathologists, we're often moaning about this, but clinical data information is really important when we're making a decision about what the diagnosis for our patients is. So again, one thing for the junior doctors who might be on the call tonight, any details that you can provide about the clinical situation of the patient, the signs and symptoms of the presentation, or how they're actually doing, can be really important in actually making a accurate diagnosis for our patients. So please keep that in mind. So a clinical update from now. She's clearly very unwell from these blood results that we've seen. A lot of things going on here. A re-examination of the patient shows that her vital signs are getting worse, with a tachycardia and a low blood pressure as well. So things are deteriorating. So the GP organises her admission to hospital for further investigation. So I think that we can all agree that's entirely appropriate at the moment. Now, I've got a poll for you now. So it doesn't matter what you think, but there are lots of different potential options that we could do for this patient now. So if you were perhaps one of the junior doctors or the medical students that perhaps have been clerking the patient in, what do you think you would want to do next, perhaps, or what results do you think you might want to see? So perhaps I can hand over to Chris to do a quick poll, or open the poll, and see which one you think you might like to do, and we'll give that a few seconds. Like I said, no right or wrong answers tonight, and you can do whatever you like, and let's see what everybody wants to do. Okay, can we close that now, Chris? And so, right, brilliant. So we've got a clear leader, so blood cultures and viral screens. So I think I'd be in favour of that as well. So we've got someone who's pyrexial, they've got a temperature. They've shown, again, the white cells are on the low side as well, which could fit with infection. And also we've got potentially problems with the kidneys. So some perhaps acute renal failure. We don't know whether this is chronic though, but we need to take that in consideration. And now we've got a tachycardia and someone who's hypotensive as well. So potentially sepsis on a background of this as well. So I think we've got a good plan ahead, really, to look at perhaps some blood cultures or a viral screen for this patient. So that's what has actually been done. And the blood culture result is actually negative to date. But what we do have is we have cytomegalovirus antibody IgM positive and cytomegalovirus antibody IgG positive on our viral screen. Other viral screens are negative at the moment. So, I'll just go back. Let's call up our microbiology, infection and virology colleagues. So I think we've got Ali and Ian on the line now. So Ali and Ian, any thoughts about how you'd interpret these in the context of what we've got at the moment, the other investigations that have been done so far as well?
So I think the first thing to do is look at the result and see if that correlates with the patient and the patient's story. So is this a positive result for cytomegalovirus infection? Does that cause hepatitis? So it does. So then it's to try and work out whether or not that's the infection that's causing the problem. So IgM is often positive in the acute phase, which we do have an acute infection here, but it can be false positive. And so I would want to know what the other viral screens that we did are that are negative, and make sure that we've done all the tests that could be causing a false positive reaction with that IgM. If the IgG is positive, that immunoglobulin tends to go up later in the infection. So I would want to know how long ago the CMV infection was. So it just means that they've had an infection at some point. So you could look at the IgG avidity. So you could request that as an extra test to see how closely bound the immunoglobulin is, and therefore how old the infection is, and whether or not that fits with our clinical picture.
That's really useful, Ali. So there are potential tests that you can do that can give you an indication of when the patient was infected. So that give you a time scale, which is often really important with these sort of results. You mentioned about other viral screens. Is there anything that will come to your mind about this patient that you'd want to perhaps do or look for as well?
So we would always do the bloodborne hepatitis viruses, so hepatitis A, B, C, and E, and we would also want to look for EBV. So EBV can often cross-react with the CMV and might give you a false positive for that. So those things, you'd want to look at those, find out what the other viral screens are that they've done.
That's brilliant. That's lovely. Thanks very much for that, Ali. Really useful. So we've got, again, some of a positive virology investigation here that may correlate, again, with some of the figures that we've seen earlier. We've seen those deranged liver function tests, and we've also seen the enlarged liver on the clinical examination, and a patient that's potentially showing some signs of sepsis here as well. So again, starting to put the jigsaw pieces together from 3 specialties we've had so far. Now we've got a bone marrow biopsy as well. So that was one of the other options that was on our investigation list. So they've decided to take things a step further and to have a look at what's going on in the bone marrow. And remember, those blood results at the beginning were showing quite severe derangements in the initial phase as well. So this is what we've got on the screen here, and we can see again some red blood cells here, and perhaps a few white blood cells alongside here, but we've also got these things here that are just floating in the background here. Now, I'm not very used to looking at blood films here, so we'll see if anybody in the audience actually is as well. So we'll set up another poll now. So what do you think these cells actually are? We can go for macrophages, normal lymphocytes, histiocytes, megakaryocytes, or atypical lymphocytes. So Kristen, can we perhaps set the poll and see what everybody thinks? So let's give everybody a few seconds to think what they might be. Okay, let's see what people think. How good is... Oh, so we've got a bit of a mixture here. So we've got almost a tie, actually. So just leading the way are megakaryocytes. So one of the primitive forms of one of the hematopoietic stem cells of the bone marrow that help to produce our platelets. But also running a close second behind that are the atypical lymphocytes. But very few people think macrophages, normal lymphocytes, and histiocytes. So I think we need to probably go to our experts here. So potentially we could speak to our immunologists or our hematologists here. Shwaib, do you have any idea what you think these might be?
I think looking into this, Matt, look nasty for me. That's not normal.
So you're not a bit worried about this, picture?
Absolutely, absolutely. And we always work with hematologists in a very beautiful MDT, so multidisciplinary team meeting, to actually go through a bone marrow biopsy and also the markers we can do using our monoclonal immunoglobulins and the markers, so all the CD markers, which we can talk about later.
Okay, fantastic. So what's your thought about this? What do you think they actually are, though?
So for me, it looks like you've got a massive nucleus and a very tiny cytoplasm. Looks for me is atypical lymphocyte here.
Okay, brilliant. Thanks very much, Ray. That's really helpful. Catherine, Thomas, do you have any thoughts about this as well? Again, bone marrow biopsies, you're perhaps one of your things you look at very frequently. So what are your thoughts? Do you agree with Shwaib here?
Okay. So I definitely agree with him here, and also with your assessment that these clearly atypical, it's clearly abnormal. So what strikes is the size of the cells, and that's probably also why some in the audience may have thought these are megakaryocytes, because megakaryocytes are very large cells, but they are clearly not megakaryocytes. There are many features that distinguish them from them.
What are some of the differences, Thomas? What would normally a megakaryocyte perhaps look like?
The megakaryocyte would be even bigger.
Okay.
And they would normally have a different appearance of the nucleus, and the nucleus would usually have sort of a lobated appearance, and the cytoplasm would also stain differently. So they're entirely different cells. Now, if I look at that, I can only think of two things that look like that. It's either an acute leukemia or a high-grade lymphoma.
Okay, fantastic. And what would your next steps be then as well? What would you now having got this result, what would your process be?
I would have hoped that together with the bone marrow aspirate, they would have also done a refined biopsy so we can get some histopathology on it. So what we would have to do is we would suspect, I mean, I would suspect high-grade lymphoma here, and I would start off by doing an immune histochemistry. So we do an H&E stain, and then we do, alongside with that, we would also do CD20, CD19, and we would do CD3 to distinguish whether it is a B lymphocytes, a B lymphoma, or a T cell lymphoma. And then we can also do immunoglobulins, IgM, for example. And then we can do other markers like CD5, CD10, which may be elevated in other lymphomas as well. So this would form sort of a basic first panel, and then we would look at that, and then we can decide further.
Brilliant, thanks, Thomas. So you'd actually bring the histopathologist in at this point as well, cellular pathologist in to see what their interpretation of the biopsy was. And do you think, both you and Shoaib, do you think the potential, you said about sort of high-grade lymphoma being in the differential now, would that fit with the investigations we've seen so far and some of the other results, perhaps earlier on?
Absolutely. This patient is not well at all. So definitely looks like she deteriorated really quickly. So there's something going on here. Absolutely.
Yeah, I agree with him as well. High-grade lymphoma is an acute illness and would account for the symptoms that she presented with. So she presented with hyperexia, and there's sign of bone marrow failure with their thrombocytopenia and the anemia that she has had. Hemolysis is still possible as well. It can be found with some lymphomas as well as it's a phenomenon, particularly with T-cell lymphoma, like angioimmunoblastic T-cell lymphoma, for example. So that could go hand in hand with that. And also, of course, because lymphoma infiltrates other organs, particularly liver and spleen, this could account for the hepatomegaly that we saw, as well as for the mildly deranged liver function tests.
Brilliant. So it may not even be the cytomegalovirus that's the infection that may be responsible for that. It may be actually the lymphoma directly itself through infiltration. It
is possible that there's also CMV infection, of course, because there's breakdown of the immune system in patients like that have a sort of acute overwhelming lymphoma. So it's possible this may be just a bystander, a passenger infection. We can't say for sure here.
Okay. That's really useful input. Thank you very much to our immunologists and hematologists for that really useful assessment of this. So we're now got us looking at immunophenotype of the cells here, and we've got markers that are positive for CD20, CD5, and CD10. So I'm going to come back to you, Shoaib, again. What do we mean by immunophenotype here, and what is this investigation?
Oh, this is what I love in immunology, Matt. Is I'm looking into these cells are kind of human being with different uniform. So each CD marker is a uniform for a different cell. So you've got the CD3 is where the uniform of the T cell, CD20, usually the B cell love to wear that. CD5 and 10 is usually the nasty B cells try to kind of wear different things. And then you see CD29 for the epithelial cells, 54 for adhesion molecules. And you have got many of these CD markers. But obviously certain ones will make me think, we're dealing with something totally different here. So CD20 is B cell, it's fine. But when you have got CD5 or CD10, I'm not happy with that. I'm going to deal with B cell lymphoma, something similar to that.
That's brilliant. Thanks, Shoaib. I always like to think of the immuno as like it's almost like a little, with the cells, they have proteins on their surface. And it's almost like with countries that have a particular flag that's specific for their country. The the different cells of our body have different flags on their surface. So if we provide the right antibody, we can get them to light up brown, and it gives us an indication of what those cells are doing. And we use that for a lot of aspects of pathology. So we've got another clinical update here. So the patient's, again, not doing very well at the moment. We're a little bit worried about the diagnosis here. We've got potential signs of a high-grade tumor, high-grade lymphoma here. And she's complaining now of increasing headaches, and she appears a lot more confused. and she's now become aphasic, which is, for those not so familiar, that's a problem with communication, either understanding or actually verbal communication to people around you. And that's often associated with a problem with the left part of the aspect of the brain, in particular the left temporal lobe of the brain. She then has a seizure. We're not told what type of seizure it is. It could be a generalized seizure, or it could be a more specific complex seizure where the patient actually retains consciousness. It may be a particular limb that's twitching. So we're not given the details of that, but an emergency scan is organized in order to try and see what's going on. So we've got an MRI scan, and the point of this bit here is to show you that it's not just pathology, other pathology specialties that are going to be involved. We also need radiology input as well. And so we often all have, pathologists will have access to different scans that are done of the body and looking at the reports. And so it's really important to get radiological input for investigations as well, to help give us a clue as to what we might actually be dealing with. And so on the left-hand side, we've got a normal MRI scan. And to give you an idea about what we're looking at, we always look at it, the patient's lying down, and we look at this scan as if we're looking up from their feet. So where my arrow is on the screen now, that's where their nose would be, and this is the back of their head here. And when looking at an MRI scan, we're always looking for symmetry, so it should be the same on both sides. And on the right-hand side, we've actually got our patient scan. And compared to the normal, hopefully you can see that there are quite some significant changes on here which are different. So the first thing to draw your attention is towards the back of the head of the patient. There's a lot more of this white signal or enhancement that's lighting up here. So, and also particularly around, we can see the ventricles here, which are indicated by the black dark staining here on this MRI. That's where the fluid, the CSF, is floating. But there is a lot of enhancement, we call, on this MRI and it's quite generalized as well over quite a large area. So I'm going to hand it over to you now. What do you think the scan might show? So do we think we've got quite a broad differentials here? Could it be hemorrhage? Could it be infection? Could it be inflammation? Could it be malignancy or tumor? Or could it be degenerative changes? What do we think? So let's open the poll up, Chris. What do we think people think the differential might be from this now? So let's give everybody a few seconds to see how their interpretation of MRI scans is. What do we think might be going on? Okay, let's have a look and see what people thought. Okay, so interesting. So the inflammation is the most frequent here, with about 50% of our respondents saying that inflammation. Our next most frequent, we've got joint, hemorrhage, and malignancy. Okay, so those are the ones we're thinking about most of all. And again, maybe because of this generalized sort of picture, people were thinking more about the inflammation side of things as well, and particularly with what we've seen from on our abnormalities that we've seen on our other investigations, and potentially with the possibility of infection. I think the differential is very broad here for what it could be. And we certainly need to make sure we get an official report from the radiologists to confirm what they were thinking. So we're back to the clinical picture again. So the patient continues to decline, and unfortunately her conscious level rapidly deteriorates. Seizure activity continues, and she has a cardiac arrest and is unable to resuscitate. They're unable to resuscitate her, which is a very sad outcome for this patient. And a post-mortem is requested. It is not clear what the cause actually is. So the post-mortems are about a very small, it's actually, if you ask the general public about what they think a pathologist does, post-mortems are probably the most frequent thing that people come back with, but it's actually only about 3 to 5% of the work of a cellular pathologist. And also one other thing to mention is that the Royal College of Pathologists is actually the lead for the medical examiner program, which has now been implemented across the country, where pathologists are responsible. Well, the college is actually leading on training of medical examiners across different specialties, really, because all hospital deaths are now being reviewed by a medical examiner, and it's a way of actually getting involved in coronial work if that's something you're particularly interested in as well. So another benefit potentially of getting involved in pathology. So we're looking at, they've done the post-mortem, but again, nothing clear on the post-mortem that they can find a cause of death. So they've done some post-mortem histology, but we've got a particular organ that we're looking at here. So what organ is this normal histology from? So let's have it, let's go back. Can we do the poll again, Chris? What organ do we think we're looking at here? So what do we think it's liver? Do we think that was kidney, skin, lung, or heart? So we're going right the way back to the early stages of medical school for some of us, or maybe a bit sooner for others. So what do we think it is? Let's close the poll And kidney, fantastic, and that's exactly what it is. So that was a bit of kidney that we were looking at down the microscope, fantastic. And then if we have a look at the next bit of histology that we've got here, so this is post-mortem histology of another organ system. So you can see a bit less cellular this time, a lot of pink material, fibrillary material around these cells, lots of different types of cells potentially here as well. So again, if we go to the pole, what do we think the histology is here? So again, liver, kidney, skin, lung, brain. Which one do we think we're looking at in this case? Okay, Chris, let's close the poll. And fantastic, 54% said brain, and in fact that's exactly what it is. So we've got a lot of budding cellular pathologists already out there. That's fantastic. So let's have a look and see what the post-mortem histology showed of the brain here. So I'm actually going to come to our cellular pathologists here, Mike and Katie. If you saw this down the microscope, Mike or Katie, what do you think? What would your impression be? Any thoughts about this?
I think it's probably the brain, so I'd send it to you, Matt.
Okay.
No, I think that there's, as one of our colleagues said earlier, I'm less worried about the brain itself and more worried about these cells that are in the blood vessels here. They look very big and very nasty.
Absolutely. And as you're quite right, and as a neuropathologist, that's certainly the thing I'd be most apparent about. We're looking here, just to orientate you, everybody. This is some of the normal brain tissue around here, but we're looking at a vessel here. You can see the endothelial cells, but all of these cells here look quite abnormal, and they're all different sizes and shapes. And also in the blood vessel, we should be seeing lots of red blood cells. We shouldn't be seeing large collections of these atypical cells here. And again, if we look at the size of them, this is probably the normal size, and these ones are about 3, 4, 5 times the size of that as well, something we call pleomorphism. So again, atypical lymphoid looking cells in the blood vessel. Now, if we did some immunohistochemistry, Shuaib mentioned about CD20 before, and we've just done this on an area of the kidney, and it's lit up brown here. And so again, that shows us a marker that this is in fact a B cell proliferation here. So again, immunohistochemistry really valuable in telling us the cell type. And so we can actually also, from our tissue samples now, also do some molecular pathology investigations. And this is really opening our eyes to the different mechanisms of disease here and actually helping us to confirm what type of diagnosis we might be dealing with, because there are characteristic genetics now which we can associate with particular disease conditions. And sometimes we find particular characteristics like a translocation here where 2 chromosomes are broken and rejoined at a particular point, or particular changes in the DNA, characteristic mutations, which we can screen for by doing DNA sequencing. And so molecular pathology is actually often a key component to the diagnoses nowadays, and particularly within different types of cancer. And so these 2 genes here, the MYD88 gene and CD79B gene, are also 2 mutations that are associated or can be with high-grade lymphomas. And so our diagnosis today is in fact something called intravascular large B-cell lymphoma. It's a very rare disease, but it's characterized by the growth of lymphoma cells within vessels and can be widely disseminated. It often presents with very non-specific symptoms and is very dependent on organ involvement, which is why it can be very, very difficult to actually diagnose and can actually end up leading to multi-organ failure. We've seen liver involvement, kidney involvement, and the brain involvement tonight as well. So it can be very challenging. And it's the cells, because they're lymphoma cells, but normally those cells will invade into the different tissues. But these cells are unable to migrate out of the blood vessels, which why they seem restricted in those. So there is a mutation that they have, which means that there's a difficulty in the adhesion molecules on their surface, which means they can't pass through, which makes it even more challenging for a diagnosis. So hopefully this has been an example of how pathology specialties can all be involved together in very complex cases and work to make a diagnosis for a patient. So our responsibility as medical detectives and bringing the jigsaw pieces together. So thank you very much to all our multidisciplinary team of pathologists that we had tonight for that. And now I'm running a little bit short of later than planned, but we're going to now move on to our Q&A session with our panel. So if I can ask our panel members to switch on their cameras for me so we can see everybody. Thank you all very much for taking part in that. And thank you to the delegates for contributing to the polls as well. That's fantastic. hopefully you've learned something about the different specialties. So we're going to go straight into the Q&A. So first of all, I'm actually going to start with a general question of what is the favourite part? What is your favourite aspect of your job? Perhaps I can come to Ali first of all in microbiology. What's the favourite part of what you do?
So I always say that microbiologists are like dirt, we get everywhere. So it's just the ability to work with, you know, basically every specialty and every professional in the hospital, in the community, you know, outside of medicine, you know, and get involved with people like the people on this call, you know, that are interested in becoming pathologists or interested in becoming doctors. And we have so many kind of general skills and general knowledge about lots of things, and it's just kind of that ability to just work with loads and loads of people and get involved in everything.
That's brilliant. Thanks very much, Ali. And perhaps I could come to Josh now as well. Josh, what's your favourite part of being a chemical pathologist?
Thanks, Matt. I think for me, in common with quite a few of the other pathology specialties, the fact that you can see a patient in clinic, take a sample of their blood, take it back to the laboratory, analyse it, see them again in clinic, be able to communicate those results and come up with a management plan. You really get to see that whole cycle of care. And I think that's something that's particularly unique to pathology, and it's just a real pleasure.
Well, that's great. Thanks, Josh. And yeah, there's some pathology specialties have a lot of patient face-to-face contact and others not so much. There's quite a variation depending on what specialty you're in. No, that's really good. Thank you very much for that. So I'm going to come to our questions now from our delegates. So the first one, thank you for this question. I'm an F1 and I'm keen to get into academic pathology. What is the ACF application process like at F2 level, and what should I do? Should I be unable to secure an ACF place at first? Perhaps I could come to Katie, if that's okay, Katie. Do you know about the ACF application process in histopathology, perhaps?
Yeah, I mean, I'm not an ACF myself, so I haven't been through the application process, but it is separate to the application generally. So the two kind of run alongside one another, and you do have to do both in order to get the place. The ACF one is run through Oriel, and the general one is run through like Health Education England, the London, the South East, I think, are running that at the moment. So yeah, you just have to make sure that you're doing both applications at the same time. But that does mean, to answer the second part of the question, that if you're not able to secure that ACF place in the first place, there is actually always that option that you can go back and apply for it later on. So if you're coming up to your towards the end of your ST1 year and you think, oh, I think maybe from ST2 I would like to apply for an ACF position, there's nothing stopping you from doing that. And the other thing that I would say is, as Dr. Osborne said at the start, that actually there's nothing stopping you from getting into academic pathology through another route as well. You did it that way in another route, yeah. I'm doing it in another way now. So I've just started my PhD and you've finished yours, but neither of us went down that ACF pathway. So there are other ways if you don't secure an ACF place, and definitely just get in touch with your local academic department. Get in touch with them to get really involved, because they'll help you along the way with that.
That's brilliant. Thanks very much, Katie. Yeah, I'd further reiterate that I didn't do any, hadn't been on an ACF post at all. And there are so many opportunities to get involved in academic pathology throughout your training, no matter what period, and at different times as well. So make the most of those opportunities and make yourselves aware of them as well. Definitely recommend that. Catherine, are there many opportunities in haematology to get involved in academic work?
Definitely, and I'd probably say the vast majority of our trainees will do some time out of program doing some sort of research. So a lot of people will do PhDs, and there's lots of opportunities in all sorts of subspecialties of haematology. So you might be into hemo-oncology, clotting. I'm a specialist in transfusion. I just did 1 year, but as a transfusion research fellow, doing various projects, and it's a really good way to kind of get yourself into a haematology subspecialty, make good connections when you're thinking about consultant roles. So all sorts of opportunities, but good to be thinking about it early, start making those connections, and then you can get something that you're really interested in to do for your PhD or your research.
Brilliant. Thanks very much, Catherine. We've got a question now about the application self-assessment scores included in the 2021 Histopathology ST1 application. Perhaps I could come to Joe Brinklow. Are you aware of what the self-assessment, sorry, a bit of an awkward question, but are you aware of what these are about, Joe?
No, sorry.
Oh, okay, that's all right. No problem. So we can get you a bit more information. With some of these questions, we may have to go and do a bit more research about for you. So,
Her hand up though, she might know.
Who's that? Sorry.
Ali.
Oh, Ali, have you got? Oh, brilliant.
So I can't talk about histopathology because I'm only involved in the infection recruitment. But basically, there's different achievements in different categories are given scores up to a maximum. And you're basically required to kind of score your portfolio, but the assessors do check it to check that it's accurate. So it's I think applicants should be provided with a kind of a schedule of what, you know, well in advance of what different points you get for different kind of achievements. So
that was my
it's trying to maintain those things when you're preparing your application, I suppose.
And again, relying on your professional integrity and being honest about what you've done is always important, because as you said, it will always be checked as well. So really important to do that. Thank you. I'll come back to Katie now, actually, if that's okay. So how would you advise foundation doctors prepare for a histopathology training? So my colleagues are preparing for exams, so MRCP, MRCS, and not sure what I can do prior to specialty training. Have you got any advice for them at all, Katie?
Yeah, don't try and do any exams. Don't worry about it. Don't do that. I think the best preparation that you can possibly do is to just get yourself along to the histopathology department and do your taster weeks. That's the best possible thing that you can do, is just go and experience it for yourself at that point in time. You can go and pick up books and start reading and doing things like that, but you're not going to be able to prepare for your exams until you're actually seeing the glass and looking at the material. And I really wouldn't recommend trying to do that until you start off, because I think there was another question. I don't want to jump questions, but there was another question about feeling unprepared for ST1. And one of the things that I thought was quite important to point out is that we have block teaching during the ST1 year for histopathology. And they are like I don't know how to describe it, Matt, kind of they're this kind of really intense week of kind of filling you with loads and loads and loads of information. And that's how you prepare for histopathology training. You know, the national one of those block teaching weeks was really close to the start of your training, and that's what kickstarts you into it, really. So yeah, you can try and do reading beforehand, you can try and look at things, but you're not going to be able to do much. But just get yourself out there to the department, experience it.
Thanks very much, Katie. Really useful insight. Yeah, it's a massive learning curve, I think, for all specialties within the first year, but a really enjoyable one. And certainly if you like ongoing learning, you won't get a better specialty than pathology, because even when you become a consultant, you're still a trainee. And that's a quote from one of the previous presidents. You're always a trainee, no matter what stage you are. And as you can see from behind me, I've got a massive library of books. Most pathologists have got a very similar situation in their offices as well. I'm going to talk a little bit about medical education now. I'm going to ask Ruth, are there many opportunities to get involved in medical education associated with pathology at all?
There are, yes. I think the way that pathologists work, there are lots of opportunities for informal education. And also, if it's what you're interested in, there are. Myself, it's something I've been interested in, and I've been involved with trainees, undergraduate and postgraduate level. And I think it's something that's probably done well, particularly the smaller specialties. We tend to invest quite a lot of time in education, and as well as training our pathologists, we're often in demand. But I think because pathology isn't now taught within the undergraduate course, certainly how to interpret blood test results. So we're in demand as chemical pathologists to go and speak to the junior doctors and talk to them, and also to nurses and other professional groups. So I think there's lots of opportunities if you have an interest in medical education and education more generally.
Thanks, Ruth. The thing I love about pathology is, again, you can shape it according to what your interests are. If you like research, if you like teaching, if you like public engagement, there's something for everybody, no matter what specialty you end up going into. And the wonderful thing is that the training programs make time for that for you and give you ample opportunity to do that. So definitely keep it in mind if you're interested in that. I've got another question for Joe, if that's okay, Joe. We've got someone joining from Kenya. So welcome to them. That's fantastic. Is it possible to do the RCPath exams overseas?
Yes, it is. So during the pandemic, we've moved most of our exams online, and our Part 1 examinations, which are knowledge-based tests, will be remaining online. Currently, you can take them in your place of work or home, somewhere with a very good internet connection. Our Part 2 exams will be hopefully moving back to being in person by and large, because they work better in that way, really. So we do have a couple of overseas Part 2 centres, mainly for histopathology, but they are quite intensive to get up and running. But we are running 2 in the autumn, 1 in Dubai and 1 in Cairo. So there are some opportunities to sit your Part 2 overseas as well when you get to that stage.
Brilliant. Thanks very much, Joe. That's really helpful. I'm going to come to Mike now, if that's okay, Mike. We've got a question. Is digital pathology going to have the same impact on the way we work as the introduction of the microscope? What do you think?
I don't think it will have. The microscope allowed us to look at things that we'd never been able to look at before. So digital pathology doesn't allow us to do that, but it does open up a lot of opportunities. Probably the most important for you will come into 2 areas. Firstly, it will mean that the flexibility for you to be able to work in a way that suits you will be much easier. So working from home, working at times that suit you around family responsibilities, childcare, that sort of thing, are more likely to be easy to fit in. And also where you can work in different parts of the country. So you could be essentially almost a consultant in London, but work in Aberdeen or something. So there's many ways, or even around the world, depending on various other things. That's one thing. So in terms of your day-to-day use, the other thing is that it opens up a lot of avenues for research. So that lots of work's being done and is being done about looking into images and assessment of images, artificial intelligence, but beyond that, assessment of images, scoring of images to help diagnosis in cancer and so forth. And really, digital images really help this and mean that huge amounts of data can be assessed very, very rapidly by machines and so forth, and can lead into research and very powerful tools for that. So I think those are the 2 areas that will really make dramatic effects in. So it will have huge effects, but in different ways to the microscope.
Brilliant. Thanks very much, Mike. Thank you. I've also got a question now. I'm going to come to Thomas, if that's okay. So I've got a question from Lauren. Thanks for this, Lauren. I'm interested in paediatrics and hematology, and I was wondering how the pathway into training works, as I think you can do it from both paediatrics and from adult training. Can you give any insight into that?
Yeah, certainly. So pediatric hematologists are very rare. So anyone who is interested in that is very welcome. It's true, you would be able to enter from pediatrics or from adults. At the moment, the GMC has not created pediatric hematology CCT as such. So there is only a hematology CCT, and that allows you to work either in an adult or a pediatric setting. So it doesn't matter if you come from the adult side or whether you come from the pediatric side. Eventually, if you have a CCT in hematology, you could apply for any hematology job whatsoever. But then, of course, it will depend on your experience and expertise, knowledge, and so forth. So then it depends. Probably you wouldn't apply for a pediatric job if you have only done the bare minimum in pediatrics, but it's theoretically possible. Every hematology trainee will do time in pediatrics. For those that are particularly interested in pediatrics, so I know it from the rotation that I used to be in, that's Central East London. We would have a particular interest in supporting you for that. So we would have try to create a program around it and open up opportunities for you. And we would have our rotation sort of including Great Ormond Street Hospital, and you would spend more time in Great Ormond Street Hospital so that you're more equipped with a pediatric hematology. But it's both. So the answer to your question is you can come either from pediatrics or from adult. But it's a very long way if you're coming from pediatrics and then to hematology, and then you may go back to pediatrics and complete that as well if you want to sort of dual accredit yourself a pediatrician and hematologist. It's a very long route. So have a chat about that, and get as much information as you can about this if you're interested in pediatric hematology. But it's a great many opportunities in hematology oncology. If you think about leukemias, stem cell transplant, but also sickle cell disease, red cell. So there is a lot of need for pediatric hematologists.
Thanks very much, Thomas. Thank you. I'm going to come to Ian now, if that's okay, Ian. So how can I find out about available ST posts for microbiology training after IM training, i.e. in Northwest England? Which areas and which hospitals? Any thoughts about that at all?
It kind of comes right into the same thing that's already been said by a lot of people in regards to lots of different topics, is that if there's a particular hospital or particular trust that you're interested in working in, I'd sneakily go and visit if you can, and have a chat with the people who are already working there. They are always going to be the individuals who would be best to advise you of what posts will be becoming available within the training program at the next possible entry. But also you'll get that additional information about how that particular location works and whether that'll suit you. So it's often best to have a chat with individuals who are already working within those departments to guide you. I think it's always useful information.
Thanks very much, Ian. Thank you. Very helpful. I'm going to come to Shweb now, if that's okay. So we've had a question. Do you ever feel like you're fighting for training opportunities in pathology, for example, in surgery, where you have to reach certain numbers? Is that the situation in immunology at all?
Oh, at all the opposite. I think this is what I love about immunology and pathology. We actually set to train a trainee to become a consultant. You've got plenty of time to do your exams, to train, and all that your supervisor are actually keen for you to learn. And maybe in immunology in particular, most of the center or immunology center, they usually link to university or in a tertiary hospital. So they have got as well opportunity to link with university, and again, you develop that section. So yeah, plenty of opportunity of learning within immunology, and as well cross speciality with hematology, histopathology, and other specialty if you want to kind of do some cross bridging.
Brilliant. Thanks very much, Ray. Thank you. We've had a few questions about molecular pathology as well. And one particular question says, it seems molecular pathology is more directed towards clinical scientists. Are there opportunities for doctors to specialize in molecular pathology or get involved? So I'm going to take this, but Katie can help me perhaps with this. So molecular pathology is definitely, we're certainly in the age of molecular pathology. And certainly as speaking as a neuropathologist and from Katie's side as a cellular pathologist, molecular pathology is probably something we deal with on a daily basis. In fact, probably nearly every case that I'm involved with has some form of molecular investigation associated with it. My PhD was based in molecular pathology as well, and it's certainly something from a cellular pathology point of view that in your training now will be certainly a very prominent feature. Would you agree, Katie?
Definitely. As you were saying, using it every single day, but actually locally for us, we have specific weeks of placement within molecular pathology as well, so that we can further kind of get down into the nitty-gritty and also experience some of the things which are done by scientists that we wouldn't have exposure to unless we went and communicated with those scientists. So it is really, the training program is really good for that, to be able to expose you to that, to put everything in context, so that you can then formulate your reports using that molecular pathology.
Thanks very much, Katie. And Joe, the curricula are now changing, aren't they, to include a lot more molecular aspects to the to what's expected within your training program? Is that right?
Yes, they are, and those curricula are being launched this August for all of the trainees entering the program.
That's lovely. Thanks very much. Mike, I'll come to you now. There's been a question about whether you can become a coroner at all as a doctor anymore. And I think from my understanding is we can't. The next closest thing probably is the medical examiner, which I mentioned about earlier on. But how closely do cellular pathologists work with the coroner with autopsies? And can you tell us a bit about your experience with that?
Well, anyone can become a coroner if you happen to be a qualified lawyer. So that sort of answers that question. But you're dead. Whoever asked it, you're dead right. You used to either have to be a doctor or a lawyer, but in the 2009 Justice Act, that was changed so that you have to now be a lawyer. If you go to most of the big cities around, this is England and Wales, by the way. If you're in Scotland, then there's Procurator Fiscal, which are virtually the same. If you go to most of the big cities in London, so if you went to, for example, Manchester or parts of London, most of their senior coroners are in fact still dual qualified, but some aren't. But despite that, as Matt says, there's a very, very close working relationship between coroners and pathologists in multiple different ways. Pathologists are, or any medical practitioner can be a medical examiner, and they work sort of in parallel to the coroner. They do not work for the coroner, but what they do is they look at all the death certificates and the cases at the moment in acute trust, but that's going to include community deaths going forward. And if there's anything that they flag up that hasn't been referred to the coroner, then they will refer it to the coroner. So there's a lot of cross work there. Then, of course, coroners are very, very dependent on pathologists to do post-mortems that they do. So most coroners' jurisdictions will have probably about a post-mortem rate of about 20% of cases that are referred to them, between 20 and 30%. That's about 85,000 coroners post-mortems a year. So pathologists do all of those, and that's not just done by forensic pathologists. Most of those are done by histocellular pathologists who do them and work very closely with the coroner. So it's something that if you're interested in medico-legal aspects, you could try and do forensic pathology, go into forensic pathology, which is one of our subspecialties. That is just deals with the medico-legal aspects around that. Or you can do coronial work and be a cellular pathologist. It's just another way in which you can have a variations within your career.
That's brilliant. Thank you so much, Mike. I think I'm going to draw the Q&A to a close there. I want to say thank you very much to the panel for all taking part in that. That was fantastic. And thank you very much to you, the delegates, for so many questions. It's fantastic to see so many really intuitive questions about the specialty. For those that we haven't been able to answer, and thank you to the panel who've been answering some written doing some written answers to some of these as well. We will endeavour to get an answer to these as well and distribute to them the ones that we haven't been able to cover tonight as well. So all of them will be addressed as best we can after the event as well. So without further ado, I'm now going to hand over to Dr. Abby Ghosh, who is one of the BDIAP trainee counsellors, who's going to tell us a little bit about the BDIAP, what the organisation is about and how you can potentially get involved as well. So thank you very much, Abby, and over to you.
Hi there. Thank you again. What a fantastic sort of session. I'm so glad to see so many of you here. So as Matt said, my name's Abby, and I'm a histopathology registrar based in Oxford, but I'm here today to speak a little bit on behalf of the BDIAP, which you might have noticed is the joint sponsor of this event. So I'm just going to tell you a bit about what the BDIAP is and why you might be interested in joining as foundation doctors and undergraduates. So the BDIAP is the British division of the International Academy of Pathology, which is a bit of a mouthful, I know, but it's one of the big pathology societies in the UK and obviously has international associations as well. Amongst its many activities, it organises on its own or jointly a number of educational and scientific meetings each year, including the annual joint meeting with PathSoc, as well as molecular and cut-up study days, and it's also responsible for the Histopathology journal. So now I know quite a few of you are foundation doctors, and I hope this evening and your experiences have piqued your interest in pathology in general. I'm here to tell you that joining the BDIAP is a complete no-brainer. Firstly, I mean, why? It's completely free, so it's completely free for foundation doctors to join. So that's a good start, isn't it? Secondly, it is a gateway to meetings, bursaries, and a range of other opportunities for you connected to pathology. So, for example, as a foundation member, if you join up, you'll be able to attend the BDIAP PathSoc joint meeting for free. This year's meeting between 6th to 8th July, fantastic program, guaranteed to have something that will be interesting to you. Even if it's something that you're not specifically able to engage with, it might give you a bit more of an insight into the life of a pathologist and a deeper insight into pathology in general. And of course, you'll have access to the bursaries that the BDIAP provides, including for the molecular and cut-up study days. So if you want more details about those bursaries and meetings, do visit the BDIAP website. Finally, the website, you'll have access to the website and all the content that's on there. And perhaps most importantly, you'll have access to us. So we'll be delighted to access, to answer any questions about training that you might have, applications, interviews, and pathology in general. So I'm one of the trainee counsellors for the BDIAP, but Katie is one of the other trainee counsellors, and would be delighted to help you with anything like that. Now, just because you're not a foundation doctor quite yet, doesn't mean you shouldn't be interested, quite the opposite. So as an undergraduate, firstly, be aware that the BDIAP exists, and you can join this when you become a foundation doctor. But if you're interested, I'd encourage you strongly to take a look at the grants that the BDIAP can offer you. And if you visit the website today, you might notice that that there's some student intercalated degree grants that are available to you, and you'll see more details about that on the web page itself. The deadline for the next round is the 23rd of July, so do keep an eye on that, and if you're interested, do apply. So that's pretty much it. That's pretty much it for today. I hope it's been helpful. Thank you again to everyone for this superb event. If you want more information about the BDIAP and how to join, visit the website, which is given on the slide here, www.bdiap.org. Visit our social media accounts. Thank you very much, and I hope to see you in the BDIAP soon.
Thank you very much, Abby, and thanks very much to BDIAP for sponsoring tonight. So I noticed quite a few questions in the Q&A about organising local taster days or taster weeks. And if you do want to explore your chosen pathology discipline a little bit further, then I would strongly recommend that you do this, as Matt already mentioned. In order to help you to do that, there is a way in which we can support you, and that is by, if you like, we can provide you with an official college letter to the head of department in the department that you'd like to visit, asking them to support your taster visit. And if you'd like a copy of a letter to you can just approach the department, and especially if you know them, you may not need a letter, so it's not necessary to use the letter. But if you would like a letter of introduction and to help you to get your visit supported, then just contact the college team by email and we'll be able to provide that for you. This also seems like a good time before we finish up to highlight a few competitions that we run that might be of interest to many of you. We have an annual Art of Pathology competition, and this closes this year on the 27th of August, and the theme this year is All Together Now. So that's a fantastic way to explore pathology in new ways, and there are different age categories and prizes in different age categories. There's also the Furness Prize for Science Communication. That's open until the 17th of September this year for a specialty trainee or an undergraduate who's shown excellent science communication skills. And we also have 2 essay prizes which run every year, the Histopathology Foundation Prize and the Paula Domitia Undergraduate Essay Prize. These have closed for this year, but watch out for these again next year. Last year's 2 essay prize winners were Harry Adams from Newcastle University and Shui Zhang, Foundation Year 2 doctor from Northern Ireland Foundation School, and you can read their essays on the website. And actually I would strongly recommend that you do, because they were fantastic pieces of work. So I look forward to seeing all your art and essays and fellowship applications. And with that, we've come to the end of this event. Huge thanks to all our panelists and speakers, and to the President for joining us, and special thanks to Matt for all his work putting the mystery case together and chairing the Q&A session so brilliantly. And also to Kristen and her team, Natoya and Tanya, who've worked really hard behind the scenes at organising everything so that it ran smoothly. And lastly, thank you all very much for joining us. I really hope you found it useful and have been inspired to continue your pathology journeys. Have a good evening, everyone. Goodbye.